Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of June 12, 2023. After a brief update on COVID status, I'll review some findings and updates on long COVID. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Taking a look at the CDC COVID data tracker in the past 1 week, there have been 7,212 new hospital admissions of patients with COVID. We know that testing upon hospital admission is no longer required. It's also no longer required that hospitals report when patients catch COVID while they're in the hospital, which we know is happening. So all that being said, we know that this is undercounting, but it's still a big number of people being hospitalized in 1 week's time. Nationwide, we can see that 1.2% of the total deaths in the week ending June 3rd were due to COVID-19. But now with this new CDC map, you can select deaths here in the view. And here we're looking at the past week. And so even though, as I mentioned, the national average was 1.2% of all deaths being due to COVID, if we were to look at Mississippi, we could see that 4.5% of the deaths during that week were due to COVID. So this map may be helpful as we go forward to see what's going on state by state. And so far in this pandemic, over 1.1 million people in the United States have lost their lives due to COVID-19. 39,503 of those were just in this year, 2023. And the week ending May 13th, which is the last week where we have finalized numbers, there were 764 deaths. This is the 6th week in a row that the numbers reported have continued to trend down, which is really a good thing. And this is about a month old of data, so we're going to just continue to keep an eye on this. Taking a look now at variant proportions, I'm glad to say there's not much new going on here. We're essentially dealing with all XBB subvariants of Omicron. And for right now, we're just hoping not to see anything new come on the scene. So I would love for things to stay nice and boring in this arena here. So today I want to spend most of the time talking about long COVID to provide some updates and a little bit of perspective. In some ways, there's a whole lot going on as it relates to long COVID. And in a lot of other ways, it feels like there's just not enough going on. So this is about the 5th briefing that I've done that's dedicated to long COVID. And I linked a couple of the prior briefings in the post just because they went into details on some things I'll refer to today that I might highlight, but I won't necessarily repeat. So since the beginning, it has been a challenge just trying to define what long COVID is. It's gotten a bunch of different names. We've got long COVID, we've got post-acute sequelae of COVID, or PASC. So you'll hear me referring to it as either long COVID or PASC. And there's a lot of effort going into defining and really trying to characterize long COVID. And that kind of tells you how much in the infancy stages of our understanding we really are, which can make it feel a little bit overwhelming. The way I think about it is that we have post-COVID symptoms, so things that people continue to experience for months after having the acute COVID infection. There are also post-COVID conditions, such as the new onset of diabetes, which we reviewed in detail a few weeks ago, post-COVID new onset asthma, and other respiratory conditions. I spoke a little about that last week. We have post-COVID neurological and psychiatric changes, which I reviewed in great detail 2 weeks ago. And I reviewed really the cognitive issues that we are seeing following COVID in some people. And I linked that briefing in the post because I think much of what we would call long COVID symptoms, like the brain fog, the changes in taste and smell, difficulty concentrating, are really overlapping with many of the long COVID symptoms that I'm going to talk more about today. Highlights from that briefing are that, well, first off, we still have a lot to learn about the cognitive effects of COVID and repeat COVID infection. I reviewed 3 important studies in detail there, but in summary, we've seen post-COVID new neurological and psychiatric symptoms and diagnoses. We've seen structural brain changes on MRI post-COVID. We've seen functional impairment with people doing tasks after COVID. We've seen laboratory evidence of brain alterations post-COVID. So we don't know what percent of people will have these brain effects or how to predict who will have these brain effects or whether they're reversible or not. We don't have a standardized way to evaluate it. We don't have a definitive imaging study to diagnose it, and we don't have treatment. We've also seen increases in what we call thromboembolic events, so the clots that may lead to heart attacks or strokes or other type of clotting events, and those are also increased after COVID in some people. And again, we don't know how to predict this, how to prevent it after someone's had COVID, or really how to treat it other than the usual way that we might treat those events. Then we have long COVID symptoms. And there have been over 200 different symptoms identified in long COVID. When we look at symptoms, we're really looking at the after effects from having had COVID, but it's not always clear specifically what might have caused those symptoms. So we've got over 200 post-COVID symptoms. We've got post-COVID events. We have post-COVID conditions like diabetes and asthma. And we're also seeing worsening of pre-existing chronic conditions after COVID as well. So you can see with all of this why it can get a little overwhelming, and there's this feeling of the need to kind of tame all of this information with definitions and criteria. But at the same time, there's an urgency in terms of the need to get help for people who are experiencing all of these post-COVID issues. And I think in some way accepting that it's not going to be a simple and straightforward definition, that it's actually going to be quite complex. And not only is it complex, but it is as unpredictable and varied as COVID itself. And the magnitude of what we're seeing is also massive, like COVID itself. Even though the risk of many of these post-COVID issues may be higher for those who are hospitalized, the vast majority of people who are experiencing long COVID are actually people who have what we would otherwise consider mild COVID. So unfortunately, we don't have the luxury of just focusing on people who had a more severe bout of COVID. This is something that can occur across the board, and it's already affecting tens of millions of people, and that count is only increasing every day as people continue to be infected every day and reinfected every day. And so this is just going to keep increasing until we can get a handle on how to intervene. So how many people have long COVID? The estimates are still kind of all over the place, but if we go with conservative estimates, we're still over 76 million people worldwide with long COVID. And again, that number is only increasing. And the part of that is because there's a risk of long COVID each time you catch COVID. And it's possible that the risk even increases with each time you catch COVID. So clearly we have this crisis that's been unfolding for 3 years already, yet we're still kind of in the infancy stages of our understanding of this crisis and all that is causing it. Now, I did a pretty thorough review in 2 prior briefings of 2 very important articles, and I linked both of those articles in the post because I think they're still very key to our understanding of long COVID. I'm going to provide some highlights here, and if you want to dive deeper, you can check out those 2 prior briefings, which I also linked in the post. So to summarize, there are still a number of different theories with supporting evidence about why long COVID is occurring. And it's not likely that just one of these theories is going to kind of be the winner and be the reason for all the long COVID. It's more likely that there are several different potential mechanisms that may be leading to some of these different constellations of symptoms and post-COVID conditions that we're seeing. So it's likely that long COVID is really not one thing, but it's many things, which also means that it's not going to have just one way of diagnosing it, probably. or one way of treating it probably. So there's really a lot to unpack and a lot left to learn, but I'll go over a few of the potential mechanisms of how we think long COVID is happening. So the first is that SARS-CoV-2 is persisting in the body somewhere. So it's in the tissues, it's in a reservoir. Somehow it's kind of hiding out in the body even after the acute infection. So we don't really know if SARS-CoV-2 is actually leading to chronic viral infection or a kind of a low-level infection in everyone, most, some, a subset of people. And it may be years really before we know the answer to this question, but it does appear that viral persistence or just SARS-CoV-2 just persisting in the body somewhere is a part of long COVID, at least in some subset of individuals. Another potential mechanism is that the immune system just gets thrown off, or immune dysregulation. And that immune dysregulation is what is leading to the symptoms or the after effects from COVID. And this immune dysregulation can come with a kind of a reactivation of other viruses that might be in the body, that many people have in the body, like human herpes virus or Epstein-Barr virus. That's the one that causes mononucleosis, or varicella, which can be reactivated and cause shingles. So basically, other viruses get reactivated because of the immune dysregulation that happens with COVID. And we believe we've seen that even with common viruses in children, like adenovirus, that we think may have gotten reactivated and even caused liver failure. So there have been a number of examples where we believe that this is happening, but I don't think we can say just yet if this is happening in most, all, some of the cases, or if it's just a small subset. We've also seen that SARS-CoV-2 impacts our gut biome and virome. So the bacteria and the viruses that live in our gut get thrown off by SARS-CoV-2, and that can have an impact on our entire immune system as well. Also, we know that because SARS-CoV-2 latches onto our ACE receptors, which are found virtually everywhere in our body, that the infection itself can cause a direct injury or insult to one or more of our organs, and that could lead to post-COVID effects. So if you get direct damage to your lungs, to your kidneys, to your pancreas, could that then lead to chronic issues because of organ damage? We also know that there are clots that happen and damage to the inside of our blood vessels. And again, blood vessels are all over our body. So if you have microclotting and damage to the blood vessels, this can certainly explain a number of the different manifestations, including those heart attacks and strokes. Then there are a couple of theories that are related to our immune system, either not being able to distinguish between kind of the virus and our own antigens in our body, or perhaps some type of autoimmunity going on. There have been some reassuring studies that haven't found significant, haven't found autoantibodies, which I think is good news, but I don't know that we've ruled out this kind of autoimmune issue, or what we call molecular mimicry, which is where the virus kind of structurally looks like some of our own cells, our own antigens. I don't think we've completely ruled this out as a possible mechanism. So I think that summarizes the different mechanisms that we think can be at play. And as I said, I don't think it's going to be just one or the other, and many of these would certainly be overlapping, but we can see that they each might call for a different type of approach. If we think that it's because there's virus persisting in our body, then our treatment approach would be to try to eliminate it from the body, which is why we might think about antiviral medications or even vaccination. But some of our observations have already shown that some people's long COVID improved after vaccination, and other people actually got worse. So this just underscores why it's so important for us to figure out what's causing this and acknowledge that the answer may be different for different people, and we really need a systematic way to sort all of this out. This study that I reviewed extensively in the January 17th briefing, I linked the article in the post because I strongly recommend it. I still consider it the most comprehensive and useful review of long COVID, something I refer back to frequently and I think is very handy. So I think it's an important resource for any of us working in the field and just anyone who wants to understand more about long COVID. Now I'm going to review a recent article published in JAMA Network on May 25th, 2023, called Development of a Definition of Postacute Sequelae of SARS-CoV-2 Infection. And this is part of the RECOVER trial, which is the $1.2 billion investment by the US government to advance our understanding of long COVID. And what they were trying to figure out in this part of the RECOVER study is what symptoms are present in people who had COVID 6 months or more after their infection compared with people who were never infected. And they were trying to use this to figure out what criteria could be applied to identify long COVID cases. So if it sounds a little confusing, it kind of is, because they're basically using symptoms of people who have long COVID to define who has long COVID. So it might seem a little bit circular, but we do have to start somewhere. This study looked at 9,764 participants recruited from 85 different sites across the United States. And these were all adults with a median age of 47 years old. And 15% were listed as Hispanic or Latino, and another 15% were listed as non-Hispanic Black. And that is pretty decent race ethnicity representation compared to what we're used to seeing in clinical trials, so that's encouraging. And what they found was that 37 different symptoms were significant in those who were infected previously compared to those who were not. And those included fatigue, especially the fatigue that happens after you exert yourself, also brain fog, dizziness, some GI symptoms, heart palpitations, change in sexual desire or capacity, loss of smell or taste, or change in smell or taste, cough, chest pain, and abnormal movements. And they also found that out of over 2,000 people that first got infected on or after December 1st, 2021, 10% of them still had long COVID after 6 months, and that's pretty consistent with what we've seen in other studies. So here you can see the 12 symptoms that they found corresponded the most strongly with long COVID. And they proposed this scoring in order to attempt to create some definition around long COVID. So they assigned a score to these top 12 symptoms that were the most correlated with long COVID. They also did some work to kind of categorize people with long COVID into 4 different clusters. I'm not going to go into that, but you can review the article, which is linked in the post if you're interested. And as every research paper does, this study reviewed some of its limitations. They listed 6 limitations, and the 6th limitation is the one I'm going to start with, which is that there are more than 200 symptoms of long COVID or PASC. And each and every one of those symptoms could be life-altering and debilitating. So the symptoms that they put here don't account for all of those. The symptoms that they're highlighting on that table and in this framework may not reflect the overall picture, may not reflect the severity or the impact or any of those other 190-something symptoms. So that is important, right? This is not all inclusive, and this leaves out a lot. Secondly, COVID is still happening. The study is still happening. And there are people in the trial who are not yet eligible for this component of the study. So this is all a work in progress. And the authors made a point of saying that numerous times. This is an attempt to create a framework, but it's not the end all be all. Another important point they brought up is that how severe a person's long COVID is may impact their participation in the study. This is obviously logical and very important to highlight, because someone who's very debilitated may not be able to drag themselves around to the different appointments or focus on the different aspects of participating in a study. They just might not have the energy to do it. So that would mean that the people remaining in the study are likely not among the most severe. So certainly this can skew the findings. So again, this is not going to be the end all. It's a starting point. Now I'm going to add a couple of other things I consider limitations, and a couple of them are actually interesting findings of the study itself. They just didn't necessarily make it into the framework yet, because again, this is a starting point. So first off, they found that long COVID was lower among fully vaccinated people than unvaccinated people. And this was different with different variants. But for example, after Omicron infection, under 10% among the vaccinated group had PASC or long COVID versus 17% in the unvaccinated. So this is just an area for us to do some further examination. It would seem important to see if the symptoms themselves were different between the vaccinated and unvaccinated, right? If it's less common among the vaccinated, is there a difference in the symptoms? Could that help point us in any direction about prevention or treatment? The second thing here I would consider very important is that among the people who got Omicron, long COVID was much higher among people who have been reinfected compared with people who only had one infection. So after Omicron, we saw that less than 10% of those had long COVID, while it was 20% among those with reinfection. So if you had it once, 10%, twice, 20%, so double. So this strikes me as hugely important. This is a hugely important piece of information. And once again, something where we might want to see what the difference in presentation might look like between someone who had a first infection versus a reinfection, because again, this might point us in a direction about the underlying causes or the mechanism of action. And the last limitation I'll mention is that it only looked at adults. And sadly, there is a whole world of long COVID among children. It could present differently, and we'll need to continue to build on our understanding there as well. So what the study itself concludes is that they feel that a symptom-based definition of long COVID represents the first step for identifying long COVID and serves as a launching point for further investigation. So first step, launching point. And I think that's a reasonable conclusion. What they have proposed here is a definition that, frankly, is not really a definition. It's more of a general framework to help focus some of our attention, again, a starting point. And I think there's great concern, and understandably so, that this will not be used as a first step or a launching point, but instead it will be seen as the end-all be-all, and that we'll need to use it to define long COVID, and that is absolutely not the case. The authors made that clear. I hope I am making it clear, and that we can all be making it clear that this is not a way to rule out people with long COVID. So I think it's most important that we don't misuse the findings of this study, but that we see it as one potential tool to help us get our arms around the symptoms that we're seeing most frequently in long COVID. It should not be used in the doctor's office. I'll say that again. It should not be used in the doctor's office to decide if someone has long COVID, because again, it's only including a small fraction of what we're seeing with long COVID. There is concern that this is going to be used to exclude people from clinical trials. There is concern that this is going to be used to exclude people from treatment in the future. There is concern that this is going to lead to people not being eligible for disability benefits because of their points don't add up to the criteria that's in the study. So none of that would be appropriate, and I think we all need to be really vigilant about this. We never want to unintentionally do harm, but sadly, this historically is how harm is done when findings are used against the people they're supposed to help. And this is never the intention, but we can't say unintended consequences if we can kind of see them coming. So we know that there's a tendency in medicine and really any system to try to make the process easier for the system. That's not always necessarily better for the patient. So we all need to stay vigilant and not allow this to happen. I think another huge concern is not so much what the study is addressing, but what is not being addressed. So remember, this is a $1.2 billion effort by the United States government to look into long COVID, to efficiently bring us further to understanding how to diagnose, prevent, treat long COVID. There is an urgent need for us to figure out how to diagnose, prevent, and treat long COVID. I think part of this concern is that there have been dozens of studies like the ones that I reviewed in prior briefings that do show lab abnormalities, that show brain abnormalities on MRI, that show functional abnormalities in people performing tasks. So we have studies with more objective evidence of what long COVID is doing to their bodies and to their brains. And we really need to work to integrate all of that knowledge. So I completely understand that this study is about describing the symptoms that make up long COVID, and that is important because there are so many of them, and we want to understand which ones are the most commonly correlated. But we're so far into this now that I think it's urgent that we start looking at all the lines of evidence and putting those together so that we can get to the point of treatment trials. And we're getting closer, but we need to hurry up. So along those lines, I wanted to share this study that was just published on June 10th, 2023 in the Journal of Translational Medicine. It's a little bit complicated, but I will do my best to break it down. The title is Plasma Proteome of Long COVID in Patients Indicates HIF-mediated vasculo-proliferative disease with impact on brain and heart functioning. So big fancy title, but really I thought these were fascinating and important findings on long COVID. The plasma proteome is basically all the different cells and proteins that we find in human plasma. And there have been a lot of advancements in the field, analyzing the plasma proteome. In the plasma, there's expression of thousands of different proteins. And this study analyzed those proteins as a way to understand the cells and the tissues in the body of people with COVID, with long COVID. And they compare people with long COVID to people with acute COVID and compare them to people who've never been exposed to COVID. So they have these three groups: long COVID, acutely infected with COVID, and then they actually looked at plasma people from 2019, so before COVID even existed. And they compared the plasma proteome, all these different proteins in the plasma, and they compared the three groups. And what they found is that in people with long COVID, the plasma proteome looked different. It looked different even than people who had acute COVID, and looked different from people who never had COVID. It showed specific biomarkers in people with long COVID, and these were biomarkers that were specific to the tissues of the brain and heart. So basically, they were able to find that there were differences in the cells, the distribution of the cells, the types of cells in people with long COVID compared to those with acute COVID and compared to those who never had COVID. And what this points to is two things that I think are important and hopeful. First, this may point to ways that we could diagnose long COVID by looking at biomarkers in the blood. So maybe one day we'll actually have a blood test that could give us some clues about whether someone has long COVID or how severe it is. The other thing is, when you find these biomarkers that are specific to tissues of certain organs or cells in the body, those become important places to look as we develop treatments or therapies. So those become what we call therapeutic targets. So these are the kinds of objective findings that will hopefully get us further to being able to diagnose and treat long COVID. And I'll take this opportunity to say that there are hundreds of studies going on all over the world regarding long COVID that should definitely bring us hope and optimism that we will have some breakthroughs in the future.
So if you're interested in checking out studies that are happening around long COVID, you can go to clinicaltrials.gov and you can just type in long COVID, and you can see that there are 443 studies found, and they actually search for the other search terms like post-acute COVID syndrome and so on, which is helpful. And you can see all the studies in different statuses here. But if you're interested in which ones are currently recruiting participants, you can actually select recruiting over here and apply. And then you can see 182 studies. And these are happening all over the world on different aspects of long COVID. But if you wanted to maybe get involved in one of these or find out more about what's going on near you, you can check on the map here, and then you can see where you might want to go. And in the United States, for instance, you can see that there are 13 in California. So if you're in California, then you can see the list of trials on long COVID that are recruiting in California. And you can see that we've got some at Davis and UCSF, UCLA, and so on, looking at different aspects of long COVID. So this could be really helpful if you're just interested in what's going on, or if you or a loved one might want to see about enrolling in a long COVID trial.
So in summary, long COVID is not just one thing. And even though we need a more organized understanding of what is going on, we need to resist the urge to oversimplify it to the point that we exclude people who need attention and who could help us further our understanding of long COVID. We need to listen to people who are experiencing this and offer them the support they need and deserve. This, depending on who you are, this might be being a listening ear, sharing with them what you do know, pointing them to resources like the ones I've shared today, because we've been finding that there are a lot of people who don't want to talk about this. They may be afraid of being labeled, they may be afraid of losing their livelihood, or they're not making the connection that it may be post-COVID, and family and friends and others are noticing it, but folks are, not feeling comfortable bringing it up. So we need to remove all this stigma. This is something that is affecting millions upon millions of people, and there's no shame in any of it. We need to recognize that it's going on and also offer some hope, because I think there's also a sense that some people feel like it might be pointless to talk about it because there's no cure yet. And I'm just here to say, don't underestimate how powerful and even therapeutic a listening ear can be, and definitely sharing information that can help someone or connecting them to resources is priceless. So, as we've been saying, our best bet is to avoid getting COVID in the first place. If you're someone who should be treated, get treated. Many of the hospitalizations and deaths could be avoided with timely treatment. But you can only get timely treatment if you get timely testing. Find out where you can get testing. Find out where to get your free rapid tests. Maybe you can get them from your insurance company or from a local community health center like Roots Community Health Center. And how do you know if you're someone who should take the treatment if you get COVID? Treatment is for everyone over or 50 and over, and anyone with an underlying condition. The list of underlying conditions is long. It includes common things. Up to 3/4 of the adult population may fit into this category of people at risk of a severe outcome. So please check the list. The link is in the post. Make a treatment plan now before you need it. And remember, we are still learning about the effects of repeat infections. We're still learning about post-COVID and long COVID, as we've talked about today. And what we do know is that if you caught COVID once and did fine, that is not a guarantee about the next time. So please do what you can to avoid getting infected or reinfected or spreading it to others. Gathering outdoors is always safer than indoors. If you will be gathering indoors, make efforts to improve indoor air quality, like adding HEPA filtration units, keeping central air running with a MERV 13 or higher, filter, and opening doors or windows. If you must spend time indoors with others, especially members of the public, wear a high quality filtration mask like an N95, KN95, or KF94. If you get exposed or if you have symptoms, conduct a rapid test every day or two while continuing to wear a filtration mask around others. If you or someone you spend time with unmasked would be treated for COVID, then please be extra careful. We need to get tested timely. You may want to get a more definitive PCR test, and your doctor should be able to do this just like they can do any other respiratory swab in their office. Remember, you only generally have 5 days to start treatment, and the sooner the better. Outpatient treatment reduces the risk of COVID hospitalization and death by about 80%. Please don't show up to school or work feeling sick and exposing others. Stay home and rest. If you have to go out, a well-fitted N95 mask could keep you from sickening or even killing another person. Consider using rapid tests for pre-event testing, and whoever is positive needs to excuse themselves. Also keep a guest list, so if someone turns up positive later, you can contact the group. If you test positive, contact anyone you are around, especially unmasked, for the 3 to 4 days before you started symptoms or tested positive. It is the right thing to do. And please do an antigen test to exit isolation. In general, we believe that enough virus to detect is enough to infect. And please don't push yourself. Allow yourself the time you need to fully recover. One of the articles that I linked in the post talked about that not resting when you have acute COVID was actually associated with a higher incidence of long COVID. And as always, remember to eat a balanced diet, incorporate fresh fruits and vegetables and whole grains, avoid those sodas and sugary drinks. Consider a multivitamin supplement, get your blood pressure checked, get your baseline labs drawn. get some regular physical activity, manage your stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.